Hi, I'm Maggie Chapman of NUR 213, and today I'm going to be talking to you about placenta previa straight from inside my closet because kids in quarantine don't mix. The learning objectives for today are being able to understand the pathophysiology of placenta previa, how to identify the signs and symptoms, understand the treatments that are necessary for this condition, and how to create a proper nursing diagnosis. Placenta previa is a condition found in pregnancy that occurs when the placenta is covering the cervix. In normal pregnancies, the placenta usually attaches to the uterine wall well away from the cervix, giving room for delivery, but that is not the case in placenta previa. There's three types: marginal, where it's a low-lying placenta that covers just barely the tip of the cervix; partial, where the name says it, the cervix is partly covered by the placenta; or complete, where the cervix is completely obstructed by the placenta. It only occurs in about 1 out of every 200 pregnancies, so it's not too common. And the good thing about this condition is that in most cases it typically resolves on its own. The placenta will move out of the way and the mom can go on to have a vaginal delivery. But if not, if it's still covering the placenta is still covering the cervix before delivery, a C-section will be required. They don't know exactly what causes placenta previa or why it occurs, but there are several risk factors that can increase a woman's chances of having placenta previa. Some of these: maternal age over 35, if the woman is carrying multiples, previous C-sections, and also any sort of uterine damage like fibroids or any uterine scarring can increase the chances. Smoking and cocaine use are other lifestyle modifiable risk factors that contribute to placenta previa. Signs and symptoms of placenta previa. With placenta previa, really the only sign and symptoms is painless bleeding, usually during the second or third trimester. That's really it. But most often, most women don't even know they have it until they go in for their routine ultrasound around 22 weeks. That's how they find out they have it. And then once it's determined they have it, then they will have follow-up ultrasounds, usually between 30 and 32 weeks, to see if the placenta has moved or if it's still in place. And if it's moved, then all is usually good and they can go on to have a vaginal delivery. Okay, now we're going to get into a case study. Ashley Tuchins is a 37-year-old female, gravida 2, pair 1, and she is 32 weeks pregnant with twins. She's a stay-at-home mom with a 2-year-old, and her husband has been out of town on business. She has been feeling fatigued, generally weak, and has experienced some heavy bleeding over the course of a week. She's attributed to these symptoms to doing too much around the house. When her husband finally arrives home, he sees her and is concerned about her condition. He takes her to the hospital's labor and delivery unit for evaluation. Okay. Upon arrival at the hospital, Ashley is taken to the triage and placed on an external fetal monitor. She's alert and oriented ×3, and she expresses anxiety and fear for her babies. She has generalized pallor. Her breathing is slightly labored. Her capillary refill is greater than 2 seconds, and she also has dry mucous membranes. She has slight non-pitting edema in her lower extremities. Fetal heart rate baseline is 140 beats per minute for one baby and 135 beats a minute for the other baby. She states that she has not had any pain or cramping with the bleeding. Her current vitals are blood pressure 110/85. Her pulse is 95. Her temperature is 98.8. Her respirations are 23, and her O2 stat is 88%. Her physician comes in to examine her and orders an ultrasound and a hematocrit and a hemoglobin level lab to be drawn. The ultrasound is done because it can determine, look in the mom's belly, see what's going on. The doctor knows that her symptoms are most likely placenta previa, and an ultrasound can either confirm or deny this condition. And because of her bleeding, he's worried her iron levels are low, which could be causing her low oxygen stats and her labored breathing. The doctor does an ultrasound and it shows that Ashley has complete placenta previa, which means her cervix is completely obstructed by the placenta. And the doctor determines that this is what the cause of her bleeding is. And her labs come back showing that she does have low levels of hematocrit and hemoglobin. The normal levels for hematocrit are 36% to 44%, and hers are at 33%. And hemoglobin normal levels run between 12 and 15.5, and hers are at 10. And the doctor looks at her baseline from earlier in her pregnancy, from when labs were first drawn, and knows that this is not baseline for her, so she will probably need treatment. Now that the doctor has determined what is going on with Ashley and why she's bleeding, he can prescribe her treatments and medication. Her treatments will include normal saline to replace the lost fluid volume since she's been bleeding, and she also just has some dehydration due probably to the bleeding, and then on top of being a busy stay-at-home mom to a 2-year-old and her husband being out of town, she's probably just tired and worn out. She will also need a blood transfusion to bring her hemoglobin and hematocrit levels back up, because that's affecting her. Having those low levels is affecting her perfusion throughout her body. And the doctor also decided she should stay on bed rest for the rest of her pregnancy to decrease her chances of bleeding again. It's also important with these treatments to always educate your patients. When it comes to educating about blood transfusion, make sure, type and screen. You make sure you ask the patient her blood type. Ask her if she's had any reactions, if she's ever had blood transfusions before, if she has, if she's had any reactions. Also explain to her that you will take her vitals at the beginning of the transfusion and then monitor and you will stay with her for the first 15 minutes just to make sure you're sure she's tolerating it okay. Teach her about bed rest. It can be hard as a mom to sit down to rest, especially if that means you have to stay on the bed or the couch and can't move. Just, tell her that doing this is what's best for her baby, and will give her the best chances at a healthy rest of her pregnancy, being able to carry the baby to full term, and reducing the risk of her bleeding anymore. Okay, so the doctor decided to order her normal saline like we talked about on the last slide. prenatal vitamins, and iron supplements. Again, medication. So we have to educate our patient. Um, the normal saline would just tell your patient, let you know if she has any itching or redness, pain, discomfort at her IV site. Also, the nurse needs to check for fluid volume overload, which can be done. Watch the for distension in the jugular vein. Also, the nurse can assess her lungs more frequently to listen to any crackles, see if they hear any crackles. Prenatal vitamins. Ashley Tuchins says she's been taking these her entire pregnancy, so the doctor just wants to make sure she continues to take them to just supplement her diet to make sure both her and the baby are getting the proper nutrition. And it also prenatal vitamins also usually have more iron than regular vitamins. So now it's just that she has anemia, she needs to make sure she keeps up with these. And also, in addition, the doctor has decided to give her iron supplements after the transfusion. Her iron levels, her hematocrit, her hemoglobin should all be back within normal levels. But just on the safe side, to make sure that they don't decrease again, she will need to take these supplements. With the prenatal vitamins, those can cause nausea, so we tell Ashley to take with food if it upsets her stomach. And then the iron supplements, they can cause constipation, which she just drink a lot of water, increase fiber in her diet. And also, iron can cause dark stools, but this is completely normal, so you can just tell Ashley if she sees that, there's no cause for alarm, and it just shows that the supplements are working. Okay, now we can talk about nursing diagnosis. Because Ashley has her capillary refill is slow, she's pale, she's clearly having her oxygen stats are low. She's definitely having some ineffective tissue perfusion that needs to be increased. We can tell her hemoglobin levels are low because of the lab values. Also, she's, just demonstrating those symptoms. We would like for Ashley to have show improvement for increased perfusion within 24 hours. The nurse can have several different interventions. One, monitor those vital signs, make sure her BP is within normal. We don't want that to drop with, outside the normal range. Also, the doctor probably will prescribe oxygen. If the doctor hasn't prescribed any yet, the nurse can go ahead and give up to 2 liters without an order to start bringing her O2 levels up. And also, because the doctor has ordered a blood transfusion and the normal saline, the nurse will need to prepare for an IV to be inserted. Okay, now we are going to go over some questions and answers, and I will be explaining the rationales of why each answer is correct. Question 1. Okay, we have a patient who is 33 weeks gestation. She comes into labor and delivery unit with severe bleeding due to placenta previa. Which of the following labs can the nurse anticipate the provider to order? Okay, the correct answers are, oh, and now is a select all but apply. We have hematocrit and hemoglobin. Oops. These are the correct answer because severe bleeding can cause a decrease in hematocrit and hemoglobin levels. White blood cells are would be ordered if an infection was suspected, and she doesn't have the doctor didn't feel she had any signs of infection, and the serum amylase has absolutely nothing to do with placenta previa. Question 2. A patient who is 28 weeks pregnant comes to her provider's office with complaints of bleeding and states that it is not painful. Her doctor performs an ultrasound and notes that her placenta is slightly covering her cervix. Which of the following is most likely her diagnosis? And the correct answer for this one is marginal placenta previa. The rationale behind this is because when the placenta is only slightly covering the cervix, it's marginal placenta previa. Total would be complete coverage, partial would be partly covered, and a placenta abruption is a condition where the placenta kind of spontaneously abrupts, which is not going on here, thankfully, for Ashley Two Chins. Question 3. A woman in her third trimester is diagnosed with complete placenta previa after experiencing bleeding. What severe complication of this condition should the nurse educate the woman on? And the answer is hemorrhage. Stroke, peripheral neuropathy, and hyperkalemia they're not complications of placenta previa. Okay, question 4. What symptoms should a woman be taught to look out for with placenta previa? And the answer is C, painless bleeding. This is really the only sign or symptom of placenta previa. Placenta previa doesn't cause headache, swelling of lower extremities, or blurred vision. Okay, question 5. A patient who is 25 weeks comes to the office with painless bleeding. The nurse knows these symptoms are most often associated with which condition? And the answer is A, placenta previa. Again, painless bleeding is most often, especially in the second trimester, is most often associated with placenta previa. Placental abruption, preeclampsia, gestational diabetes have a whole different class of symptoms than placenta previa. Okay, let's wrap up this PowerPoint session by finding out what happened with our patient. Ashley Tuchins was discharged from the hospital with orders to stay on bed rest for the remainder of her pregnancy and to take her medications as prescribed, and she promised to be compliant with both of those orders. She came back to the hospital at 40 weeks gestation for her scheduled C-section, and she did not experience any complications and delivered 2 healthy baby girls named Maggie and Holly. And their big sister, Yada, was thrilled to be a big sister. This concludes my presentation. I hope that you at least learned a little something that can be useful for your nursing experience in the future. Thank you.